what I will tell you now is some aspects of the vision that the National Physical Activity Promotion Program is building towards a national health service that is more conducive, more successful in promoting physical activity. I was trying to get at Mike Brennan before to get a sense of the investment that the country in the UK or England is making in promoting physical activity, just to establish a comparison of the resources and staffing and funding and professional help that we have to accomplish this task. And that's all I'm going to say. But this is only one of 6 of our priorities. So promoting physical activity in healthcare is one of, well, let's say one of 4 strategic directions of goals of the National Physical Activity Program. And I won't tell you what my budget is. And I agree with Mike that we are doing a lot. We are experts in doing a lot with not a lot of money. And a lot has been done. A lot will continue to be done with not a lot of money. But we can't do everything without financial support. And so it's important that as a society, we stand behind and resource the things that are a priority for health promotion of our nation. And we're not quite there yet. There's an expression that Luis Sardinha uses frequently, which is putting the money where your mouth is. That's generally the simple way of saying it. And we're not quite there yet. Our mouth is full, and we are very enthused and very motivated, but different steps need to be taken so that we are better resourced to accomplish our goals. And I know my colleague, Cristina Valadas, feels probably the same way about her program. I know my colleague in the Healthy Eating National Program feels the same way. Of course, we live in a country with limited resources, aren't we all? But we also need to be mindful that we cannot do omelets without eggs. So we needed a model for this roadmap. And Jonathan, which slide I stole, presented us this yesterday. It's quite a challenge, and this is something that we want to build in the future, to have a schematic representation of physical activity promotion through the healthcare system. I won't even start to describe it. He did it in a very progressive and very nice way, and he's been practicing on it for a number of months or years, I don't know. So I won't even start it, but I will say that we have the right person to help us think about this, and that's Dr. Paul Beckert, that you will hear about in the panel afterwards. He's a specialist in complex modeling, and I will count on him. We have a session long due to have a board in front of us and design this whole thing for Portugal. Meanwhile, we have a simple model. And the simple model is based on 3 main responses that the healthcare system in Portugal, from our perspective, needs to give. And that is the need to evaluate physical activity systematically in the healthcare system and sedentary behaviors as well. The need to counsel and recommend physical activity in a broad way, in a generalized way for every patient or for all patients for whom you can do that. And also the need to have those that need receive a personalized exercise prescription for a program of a formal program of exercise. And that necessarily will have to do in connection with resources in the community and with other professionals, as I've explained before. These are the 3 responses that are required in a simple model. So how can we get there? We've identified 3 pathways of this roadmap. One is to change the primary healthcare system in a way that makes that possible, those 3 goals that I've said before, or those 3 responses, and I'll show you in a second what do I mean by changing the primary healthcare system. Secondly, train health professionals and other professionals and exercise professionals. They also need to continue to improve their training to promote physical activity for everyone, for every group of the population. And finally, we need to connect the healthcare system, the primary healthcare system, in a much better way and in a more formal way, in a more trustworthy way, with resources in the community, with professionals in the community, with programs in the community, in a way that, and this is the only way that we will be able to answer the demands for physical activity promotion, for physical activity practice throughout the healthcare system. So I'll say a few words about each of these areas. What needs to change in the primary healthcare system? So we need to evaluate, and I'm glad to say that that's going to be much easier starting at some point soon, today or tomorrow or yesterday or the next day, we'll have Professor Henrique Martins, which is now here, talk about this in a moment, so I won't get into details. But the point is, the healthcare information system is being adapted so that primary care physicians and perhaps even other specialties, and this is news, can also do a brief physical activity, well, can all assess physical activity level in a very simple way. And we could discuss if these are the right questions or not, but these are the ones that we chose as the most appropriate. And the questions are actually not here, but they might come up later. I want to thank actually my colleague Cristina Valadas, because the diabetes prevention program was very instrumental in us getting a foot on the door in S-Clinic before I actually started interacting directly with SPMS, and that was how we started this conversation. So it was one of the first things that we did, and it worked very, very nicely. I guess we can also appreciate the help of our colleague that left, and Cristina Portugal, is that, which helped a lot our program initially. So the critical question there is, what's the level of risk for physical inactivity for every patient? That's the question that we are trying to get with those questions, or the diagnosis, if you'd like. And so based on that question, whether a person meets or not the recommendations, you can start the conversation, you can start brief counseling, or you can refer to the community, among other options. How many people are likely to be insufficiently active? This is a broad number that we've collected from multiple sources. So probably about 3 in 4 adults in Portugal are not sufficiently active, and they would benefit from brief counseling. And those that are also benefit from encouragement, from new directions of new proposals to continue to be active in a sustained way. By the way, we're also defining what counseling and brief advice is. And so here you have the definition that Rita already showed you yesterday, Rita Tomás, what counseling is, what the recommendation is. It's an interaction including verbal communication, verbal encouragement, an indication to initiate, and then which could be written or oral, and then a discussion about preferences, about some of the initial possibilities, and about the basics of starting your physical activity. And we know that the word of the physician, the word of a medical professional, is important for many patients. And so, in this regard, we're working with SPMS, with the Sistemas Partilhados do Ministério da Saúde. Together, my colleague Romeu Mendes, have been working very intensely with a team from SPMS to create a digital guia de aconselhamento, that's how we call it in Portugal, a brief advice pad, if you'd like. And again, I'm sure more details will be presented later, so I won't get into details. But that was, so we worked together, the DGS as the technical experts on these tools, and then we had our colleagues at SPMS providing all the technological and systems of information knowledge and expertise. What does it entail, brief counseling? Again, Rita Tomás explained it very nicely yesterday. I won't go into it. But the point is, it can be done with very little time. And we have protocols that are defined, whether you have 30 seconds, 1 minute, 2 minutes, or 5 minutes, and that's about it. That's probably about what the most typical primary care physician can have for physical activity. However, if one of the points that has become clear throughout this conference is that we have an increasing number of members of our society, of our family members, of our patients, of our colleagues that are in need of something more than brief counseling. They are in need of a structured, personalized, exercise prescription program or prescribed program. Because we know about the therapeutic effects of exercise, but we know that exercise has to be conducted under certain conditions of safety and of effectiveness. And we've heard that through many talks. I won't highlight that point, but I want to make this point very clear. This is a trend. So societies are evolving in a way that those conditions are not going backwards. They're still increasing, and because of the aging of the population and the better of healthcare, we'll have more and more people in need of this specialized care. And exercise is effective, or is very helpful for dealing with many of these conditions at different levels of the condition. And so, how do we do this? How do we provide the population with an increasing number of opportunities to have this prescribed exercise program? It's not a simple solution, and I'm providing you a vision for the future. It's not going to happen immediately, and we've had some accounts earlier today of how difficult and costly this response might be. But still, it's our obligation now to have a sense of where we want to go. If it happens next month, great. If it happens next year, we'll be happy. Otherwise, we'll keep on going until we have a response that fits the needs of our citizens. That's what we should do. That's our obligation. So as I said, this necessarily involves going outside the primary healthcare system and creating, or inside and outside, and creating solutions for these society needs. And so what we are proposing is that we have, to begin with, that we have a consultation, that we create a consultation within the primary healthcare system, perhaps one for agrupamento de centros de saúde, a group of health units, and that some patients can be referred to and get this sort of more personalized, individualized prescription that then can be turned into a group program. For instance, in the case of diabetes, we have nice examples of group programs that are supervised by a specialized professional, but still function in a group, and still the amount of evaluation, initial and follow-up that takes place is in agreement with the needs of those patients. But it also requires that connections are established between primary healthcare system and other aspects of the health system and outside the health system. And so I'll tell you a little bit more how this is going to be tested within the next 12 months or so, 15 months or so, in some specialized units, so that we can see how can we create these consultas and how can we test them to see how effective they are, what resources they take, how much problems arise, how can they be implemented. And of course, this involves more than medical and exercise professionals. This involves other types of professionals, and here are listed those that will probably be involved in some units, maybe others maybe not in others. We'll create probably different formats of this multidisciplinary work and test them and see how that works. But of course, we have other healthcare professionals that are in a way involved. They should be involved in exercise prescribed programs. And I guess physiotherapists will probably be on the first line of that because of the close connection of their scope of practice with physical exercise in general, and in prevention and rehabilitation of things that of the type of conditions that physiotherapists usually deals with. Next, connection with local resources in the community. This is going to be absolutely necessary, of course. And yesterday we've heard about some of those resources that are already out there. And now what we need to do is establish a network of trust and of accountability from one to the other. So partnerships, protocols of proximity in local communities need to be established, and we will think of ways in which these can be tested, implemented and tested in particular units, in particular regions. And we also need to count with other organizations and institutions that are already providing services for physical activity promotion, such as local city councils or other local representatives, political local representatives, or government, I guess. That's what I would say. Juntas de freguesia is what I have in mind. And other organizations, of course, health clubs, health and fitness clubs are already out there, and they are the obvious place in which exercise prescription should take place. So I want to make that very clear. But also sports clubs, associations, and also pharmacies. I'll talk about this in a moment to put a bit of water in that fire that was almost starting about pharmacies. And also, of course, specialized services provided by the most qualified professionals, which are exercise physiologists. So the key question that we've been hearing when we talk about this connection is there trust, especially from the medical community? How can I be sure that when I pass on my patient, he or she will be taken care of in the most knowledgeable way, in the most safe way, depending on in consideration of the condition that he or she has. And so that's this network of trust that I think needs to be established, and we need to have formal procedures for that to be established. They're not there yet. This is not new. If you read the recommendations, these are not new recommendations from the European Commission. It's very clear that public authorities should identify which are the professions that have the necessary competencies, in this case to promote physical activity, and how they can be articulated and applied in the relevant functions. And where appropriate, and where necessary, and it is necessary, to establish appropriate systems of recognition, of certification. And that's the direction that we need to follow, in my opinion, or in the opinion of my team. We heard yesterday how Canada has handled that, with creating professional standards and scopes of practice, defining what each professional, namely exercise professionals, are entitled to do, or are able to do, or are or what they are good for, they are trained for. and basically to ensure that quality services are provided. That's our main concern, that quality services are provided at every contact, with every patient in this case. And you've heard about some certifications that are in place in Canada, such as the certified personal trainer and the certified exercise physiologist. And you heard a lot more about how this process takes place, which I don't have time to explain, but we are happy to have a close connection, and we can talk further and learn from other experiences so we can follow the same way. So my vision is that we can create a process of recognition of exercise professionals that identifies those that are most able to work directly with the healthcare service. And I will work to establish some form of group that starts a discussion around this, and we'll see how far we can get. That's as much as I'm going to say. But you see some of the partners that I would like to have involved in this discussion. So from health to sports, which regulates exercise professions today still, and rightfully so, to the professional association of this area, to the representative of the most important employer, and also, of course, and I'm hoping that exercise medicine can also be involved in this process, as it has, for instance, in Canada. So that is my vision, that we can establish this process of formal recognition that will hopefully create this network of trust in the future, so that we can talk to each other, knowing what to expect from each other. And I could talk about it differently also from exercise professionals back to the medical community, but I won't say that now. We might need something else. We might need a network of health professionals, of specialized health professionals. You heard about the Clinical Champions program in the UK. That's a nice model in which you have health professionals, physicians and other professions that are responsible in their local units or in their regions to coordinate a number of activities related to this process that I've described. So coordinating programs, knowing which programs are in the community, helping in training, and connecting the both sides of this equation. Finally, training, and this is the easy one, and I'll go very fast because obviously this requires a lot of training. We heard a lot about this yesterday too. I asked Jonathan in particular about this, what they've been doing there in exercise and medicine in Canada. But we all know that we need training, that health professionals in particular don't have enough training in physical activity and exercise physiology. And so training needs to be postgraduate training, but also initial training during the initial courses of medicine. And we are working in different ways in which we can contribute to that agenda with the Medical Students Association, with the representative of the universities of faculties of medicine, to be able to have best formal and informal sessions or informal protocols of training, so that the conversation is easy between healthcare professionals, physicians. They know more about what they should expect. You heard yesterday about Jonathan saying something about you don't know what you don't know. Meaning that when you're not trained, you also don't ask the right questions, you don't recognize the skills of others, and that's very important for this conversation to be able to work productively. So we are working currently on a proposta de despacho, proposal for a regulation, a regulatory statement by the health service, or by the health ministry, I should say. In this case, the Secretary de Estado Adjunto da Saúde. We are working on that together with os sistemas partilhados do Ministério da Saúde and the DGS, on a proposal that provides a formal commitment to some of the directions that I've described before. And I think you should expect news very soon. We thought that it could be signed by today, but it wasn't the case. So expect some news in the near future, very near future, I think. We have a calendar too for that I won't describe in essence. I'm finishing. And we are also mandated to articulate this despacho, this new vision for the healthcare system, and also some decisions that need to be made, also with a very important commission that is already in work. And this is one of the things that I'm most proud of our work last year, to establish a multidisciplinary, multi-sectorial, intersectorial commission, or interministerial commission, if you'd like, including these areas that you see here, and which is coordinated by Professor Romeu Mendes, that's over there, on the part of the health ministry. So you can follow also the works of this commission online very soon. We have to present a national physical activity action plan before the end of the year for then our governmental governmental official to decide whether they want to do it or not. I could give you all sorts of documents providing directions, providing guidelines in the direction that I've described previously. I won't do that because these documents are known. The National Strategy for Physical Activity, The new action plan, the new global action plan that is now in discussion includes actions exactly in the direction that I've just described. This is all still in discussion, I should say, but by no means it will be forgotten. You'll see here mandate for countries in the United Nations, so all countries in the world virtually, to have to be mandated to do more in primary care systems, in health systems in general, to promote physical activity. And countries will be evaluated if this goes through, for instance, in many indicators of success. And one of them is proposed that it is the number of countries with brief counseling in primary and secondary healthcare services. So our country will be accountable to have this system in place in the next few years if this reaches the final document, which by all means it should. One final word, also from those guidelines that say that professionals, or physicians and other health professionals should be facilitating agents between patients or users of the healthcare system and those that provide physical activity programs. Facilitating agents beyond the specific actions that they do there. And this brings me to the pharmacy issue that came about because of news that were put in the news by interviews that I gave or statements that I made, and that put pharmacies in the center of exercise prescription. So this was the title of the news story. Healthcare units and pharmacies will recommend exercise programs. Important thing is that exercise prescription is performed by a specialized, qualified professional. This is how it was read. Okay, so I had to deal with this type of reaction for 3 or 4 days in Facebook and colleagues and all sorts of directions, because that's somehow how it came about. Because some colleagues did not read the full news, did not ask me sometime what did I really mean. But this anyway. So instead of having the pharmacies as a facilitating agent, which is the goal, as I'll explain, we have this we have the fire going on, but it's calmed now, and I think we'll be able to move forward. So what is this about? Pharmacies, the National Association of Pharmacies is working with the Ordem dos Nutricionistas for a couple of years, or at least a year now, in working with a program to have nutritional services provided in pharmacies in the best way possible, using the best knowledge, using the best professionals, and with oversight from the National Association. So we talked to them at some point. Actually, they talked to us, and we concluded that we wanted something similar in the area of physical activity promotion. So we started the discussion. We involved the Association for Exercise Physiology of Portugal, which is emergent, and we are working with them to start the process in which they can be a link in the community to help, for instance, link healthcare units, Centros de Saúde, with the final user. How many of you have used the gym in the last 6 months? Okay. How many of you have joined a running group in the last 6 months? How many of you have used a pharmacy in the last 6 months? You're young. Okay, in the last year. How many of you have someone aged 50 and over who've used a pharmacy in the last 6 months? Pretty much all of you. So that makes my point. Pharmacies are a unique resource already in the community. They are health professionals. They are connected with the health ministry to provide local services, proximity services with patients. So they are ideally positioned to carry this message, and we are working with them to make sure that the service, whatever it becomes in the future, it's not now, will be the best possible service in the service of users. And so, if you followed my story, you'll know the careful that we will have in making sure that that whatever process we establish, and we have to build it yet, will be the best possible process in the defense, but also in the promotion of physical activity and linking them with exercise professionals and exercise programs in the community. Anyway, we could talk more. I should also forget grassroots organizations. We have an example here of a nice one. There's several, and if we are successful in physical activity promotion, I think we also need to link healthcare services with grassroots organizations, initiatives that come from the society that, just finishing, that already have some things in place. And this is a nice one that is related to the Walk with the Dog initiative. So we must not forget energies that are already in society that we can use, providing the necessary technical oversight. So resources for you. The website of the national program has growing number of resources that you can use. I want to highlight just two. One is this book that you have, this revista, Número da Revista Fatores de Risco, that you have in your package. That was a collaboration with the Portuguese Society of Cardiology. It's a very unique set of articles talking about many of the topics that were discussed in this conference. And we also have other resources such as current data on national prevalence of physical activity, which is one of the questions that comes up more often. So finally, just a word of thanks to all of you for listening and being patient at this end of what was a long session. And I also want to thank the people that work closely to me. All of them work, as we say in Portugal, por amor à camisola, por amor à missão, with a sense of mission. They're not paid for it. Many of them have to juggle very difficult agendas in their work, in their daily work, in their paid work, to be able to be here. Cristina Valadas could probably tell you the same story from her program. But it's a work that we are excited about, that we do because we think it's important. But that should not detract us from saying that we need professional staffing, we need professional resources like the UK, for instance, has, to be able to think about this full time, to be able to meet with every person we need to meet, to be able to carry every aspect of this agenda forward. We're not there yet. I'm also not paid to do this job, although I have the most recognition because I'm the director. I also want to acknowledge the first 5 people on that list, or the second 4, because those are the ones that worked throughout the month of August to be able to give the Secretary of State a overarching view, our vision for what the healthcare service should be like in the future, and our ideas for how to get there. And we'll see which ones of those see the light of day, but we'll fight for them as we have these past few weeks in several meetings. Brief word of thank you to Catarina Silva, which helped me help this program. She's our, well, I don't know how to describe it. She does a lot of work. She's actually the most professional of all of us, and she helped also put this presentation together. So thank you all very much.